Farhan. I think there is.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहां हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Now I would like to invite Dr. Shweta Singh to introduce and invite our Vice Chancellor, sir, who is always there to encourage and boost our morale. Over to you, Dr. Shweta. Please unmute Shweta ji.
A very good morning to some of you and a very good morning to others. And it's a very warm welcome to our chief patron, our patron and the chairperson. I have been instructed to take a very brief session, so I'll try to do that. And on behalf of the organizing committee, it's my proud privilege to say a few words about our Honorable Vice Chancellor, Dr. Bipin Puri. To begin with, many of us would not be knowing that Sir belongs to Lucknow itself. He had his schooling from prestigious La Martiniere School after completing MBBS in 1978. He did MS in General Surgery from Armed Forces Medical College, Pune, and MCH in Pediatric Surgery from PGI, Chandigarh. Sir dedicated 40 years of his medical services to the armed forces and was superannuated as Director General in the year 2019. He served as honorary surgeon to the Honorable President of India. Sir was awarded with Param Vishisht Seva Medal and also Vishisht Seva Medal for his distinguished contributions. He has been Emeritus Professor at ICMR and has been governing and advisory committee of member of these committees of AIMS, NMC, NBEMS, and many others. In August 21, Sir was appointed as VC of the King George Medical University. He's been the first Army Lieutenant General to be appointed as VC of any medical university of our country. Sir joined during the COVID pandemic, and despite multiple challenges and hardships, he has taken our medical university to greater heights. Uh, Whether it is fighting against COVID in the best way possible, to providing good quality treatment to the patients, or training the students in the modern era with using better technology, or promoting research and development related work. I'm not sure how much justice I've been able to do in terms of, speaking about the achievements of justice, because I'm allowed only for a short span of time. But still, I just hope I have done some justice, sir. Uh, and now I would like to say something from the organizing committee. Our committee is immensely grateful to you for being our patron in supporting us and giving us every possible opportunity, every possible support. And most of all, thanks for your time and for being here. Sir, I take this opportunity to invite you to grace the occasion and bestow us with your blessings upon us. Um,
Thank you, Shweta. Thank you for your very kind words. So let me begin with by addressing Professor Jared B. Cass, Fulbright Specialist in Global and Public Health, Bureau of Educational and Cultural Affairs, U.S. Department of State, and I was also Professor Emeritus Department of Counseling and Psychology at Lesley University. So on behalf of the King George Medical University, I extend a very, very warm welcome to you, Professor Jared Cass. On the webinar today, of course, is Professor Shaili Avasti, who's the Dean Research and Development of this university, Professor Shrikant Srivastav, who's the Head Department of Geriatric Mental Health, Professor Monica Agarwal, who's also the Head of Social and Preventive Medicine of this university, Professor Soumendra Vikram Singh, who's a co-faculty in charge, Research and Development, and there are many more very eminent people of the university, and I'm told that a lot of other delegates have joined in on this online platform. Once again, to all our delegates, students, ladies and gentlemen, I once again, on behalf of the university, extend to you all a very, very warm welcome. So let me begin with my conveying my compliments to the Department of Research and Development, the research wing of this college university, and the IQOC for organizing this online international webinar on mixed methods of research. I must admit, I myself had to do a little bit of a reading and understanding of what it exactly means. But of course, we'll try and understand this better once the expert comes on board. But let me begin with by saying, and just talking about my own viewpoint and how I have looked at research methodologies in the times bygone. So let me say this, that it is indeed an increasing issue of relevance, importance, very contemporary. Whether it's going to be a qualitative assessment or whether it's going to be a quantitative assessment has always been, we are always trying to understand whether it should be subjective or more objective, or should it be a combination of both. I think if I understand the subject right, it is basically trying to bridge this gap between qualitative and quantitative, and see if you could get somewhere in between, and see if you can get a better assessment of research methodologies. And I think towards, I know one system could be superior, and I sincerely believe it's always best to have the best of both the worlds. And towards that extent, I think we are very, very fortunate this afternoon to have a Fulbright scholar specialist, Professor Jared Dikas, to help us to understand this, this issue and see how in today's times, today's changing times, when there is so much of data, how to make useful a sense of this data and try and how to analyze the data and try and make the most of it. So I think with these few words, once again, I thank the organizers for giving me a chance to begin this proceedings, and once again, I wish this webinar a resounding success in its deliberations. Thank you, Professor Jadkas, for being with us this afternoon. Thank you. If you could please take this forward.
You need to unmute yourself, Dr. Nisha.
Okay, sorry. Sorry. Thank you very much, sir, for your kind words, for your blessings, encouragement, and motivation. The time has come to invite our speaker, Professor Jared Dikas, and for formal introduction, I would like to say that Dr. Kas is a PhD who is a Fulbright specialist. He directs a clinical concentration in mind, body, behavioral health, and wellness. During his 4 decades of research in health and counseling psychology, he has investigated an integrative approach to mind, body, and spirit in psychotherapy that utilizes trauma-informed, culturally responsive, person-centered methodology, in which Dr. Kas always talk about we have to reduce the chain of pain. He always discuss it. He has published many papers and books, chapters about his research studying the relationship between physical, psychological, social, and spiritual well-being. His book, A Person-Centered Approach to Psycho-Spiritual Maturation, Mentoring Psychological Resilience and Inclusive Community in Higher Education, presents his most recent findings. His work demonstrates multidimensional pathways through which person-centered psycho-spiritual development can contribute to individual and social well-being through the formation of resilient worldview, and pro-social behavioral changes can be occurred. He has the opportunity to work with Dr. Carl Rogers, who is the pioneers of humanistic approaches in psychotherapy and education. And he worked a lot. Now over to you, Professor Kas. Thank you.
Thank you very much, Dr. Pandey. It's a great pleasure and an honor to be here and to be speaking with you. And let me myself also thank Vice Chancellor Dr. Lieutenant General Dr. Puri and for his kind words, and also as he explained the exact theme of the talk that I'd like to give today. And I appreciate his wise insights already about the importance of balancing quantitative and qualitative approaches when we're working with patients and when we're conducting research. And it's let me also acknowledge Pro Vice Chancellor Dr. Vineet Sharma and Dean of Academics Dr. Uma Singh, and of course Dean of Research and Development Dr. Avasti for helping to really organize and arrange this presentation and to have interest in this subject. And let me mention also the advisory committee, Dr. Srivastava and Dr. Agarwal and Shweta Singh. Thank you for your good words. And Somendra Vikram Singh, Dr. Singh, for your introductions. It's just a pleasure to be here. And some of you know that I've been collaborating with Dr. Pandey for many years now and appreciate her insights and appreciate the support that she's given to my work. I have great respect and love for Indian culture and spiritual traditions. I've learned so much personally and professionally. And I'm sure that many of in my life, I'm sure that many of you will hear in the presentation that I'll make the deep sense of connection that I feel to important ideas that emerge from the Bhagavad Gita and many of the other important spiritual texts of India. Let me then just share a screen and dive in. And let me see if we can get this to full screen view.
Yes.
Good. Can you see the screen okay then? Is that good?
Yeah.
Good. I just would quickly like to mention my a second and third author of this presentation. You can see them in the lower left of the screen. Joanna Garcia. These are both former students of mine who are now doing clinical work, but continue to be research associates. Joanna Garcia works with many women of color and students of color, particularly in the areas of domestic violence. And she's now a clinical counselor at LaSalle University in Massachusetts. And Nicole Peterson, who herself is certified as an Ayurvedic practitioner, studied with Dr. Vasant Lad in New Mexico, and a registered yoga teacher. So it's been a pleasure to work with many students in the United States who also share the interests and the approaches that I think are emerging these days. So let me just jump right into the objectives of our seminar. First, to explain the goal of the particular research project that Dr. Pandey and I are exploring and working on and hoping to continue further to promote resilient aging across the lifespan through psychological growth. But of course, our focus today will be number 2, to discuss research design, particularly mixed methods with semi-structured interviews. And we're going to spend both time on how this is an effective methodology to study resilient aging, but how it would be an effective methodology for many other health-related and health promotion studies, and to look particularly at how mixed methods that really unify quantitative and qualitative approaches, but use a particular qualitative approach, semi-structured interviews, as a way to gather data. And to do that, number 3, I'm going to introduce to you the inventory of positive psychological attitudes. And this is a standardized research instrument that has strong psychometric properties that I helped to develop in 1991. It measures a resilient worldview, confidence in life and self. And you'll hear me return to this theme many times, the importance of developing confidence in self, but also confidence in life, despite all the hardships and the stress and the struggles that we face. And the IPPA is used regularly for quantitative research on resilience, but you'll also see during this presentation that the 32 items of the IPPA also provide a framework for semi-structured clinical interviews. And then 4, we'll sort of turn from there to discuss the art and science of semi-structured clinical interviews. And I'll try to offer some practical tips for conducting an in-depth interview, both as a clinical tool and as a research tool. And then number 5, I'll present a concrete example, a semi-structured clinical interview that uses the IPPA to promote resilient aging with a particular patient, an adult male with a history of heart disease. And you'll see that this patient was very defensive and resistant to any kind of behavioral medicine interventions or mental health counseling. That was part of the issue and difficulty for him because he did not understand the connection between his psychological well-being and his own physical health. And finally, after that example, I will discuss a potential application of these behavioral medicine concepts and this methodological approach, speaking a little bit more specifically about a project that Dr. Pandey and I are working on, resilient aging across the lifespan, and hoping that there will be some collaboration between KGMU and the University of Lucknow, particularly because in their Department of Psychology, they're doing some very excellent work on the area of positive psychology. So off we go to number one, looking just quickly at the goal of this research project to promote resilient aging across the lifespan through psychological growth. And I'll simply, well, let me mention quickly too, I'm going to try and move quickly through some of these early overheads because there's a lot of material to cover. And Dr. Pandey has assured me that each of you will be able to have access to these overheads. So if I'm moving quickly, I apologize, but I'm doing it on purpose, and you'll be able to come back to these. So you don't need to worry about just getting careful notes on every one of them sort of right at this moment. So back to the goal of the project, that within the field of behavioral medicine, there is very strong evidence that patients' psychological attitudes can either strengthen or undermine successful treatment and prevention of medical illnesses. So two examples. One, the most clear, is compliance with prescribed treatments. Patients' compliance with treatments, whether it's medications, physical exercise, healthy diet, or participating in a cessation program for smoking or alcohol or drug dependence, all of these aspects of compliance are affected by their worldview. Because if a patient feels hopeless or helpless or bitter in their lives, then their motivation to comply is reduced. And conversely, if their worldview is resilient, if they have confidence in life and self, then their motivation is increased. And we know that through a great deal of research by now. And the second example, equally important, are mind-body interactions that we've learned about over the past decades. We know that psychological stress dysregulates healthy functioning of the autonomic nervous system and the hypothalamic pituitary adrenal axis, producing negative health consequences that affect, for example, dysfunction in many systems, in the cardiovascular system, cognitive functioning, digestive system, the immune functions, and musculoskeletal systems. So when psychological stress is not acknowledged, or when it's not managed with effective coping skills, negative and very severe negative health consequences proliferate. So we can say that we can conclude from this previous work in behavioral medicine, but we can also offer as a hypothesis for this particular study that helping patients strengthen a resilient worldview, confidence in life and self, may be a vital psychological aspect of treatment and prevention methods to promote healthy aging. And of course, that's why we're going to need to look at a complex research design. So on to number two, to talk a little bit more about mixed methods. Yes, Dr. Pandey.
No, sorry, the slides are not moving.
The slides are not.
I think you need to go to the slideshow view.
Yeah.
Oh, okay. In other words, go back to, how's that?
This is only first slide.
This is,
Yeah. Now this is on research design.
now it's working?
Yeah, it's good.
Okay. So I'll keep it like this then?
Yeah.
Okay. All right. I'm moving the gallery around because it's blocking my view and just figuring out how to do that. Okay. Is that looking okay now?
The slide is still not occupying the entire screen as it should, sir. It's the view where the slides are playing on one side of the screen so yeah, you need to change the view, I think.
Yeah,
Please no.
that's what I'm
Please
sorry.
do the slideshow.
I had it on slideshow, but I'm afraid that didn't. Okay, let me just see what we can do here. I'm putting it on slideshow.
Slideshow for full screen may work.
Is that slideshow visible now?
Is that disabled?
No,
I don't think.
it's still the same screen. Yeah. Now, so the screen is blank, but this is the view that we want.
The screen is blank. I'm not sure what to do because I'm looking on my computer and it's visible.
Maybe there's an option.
Can you please
Can you please close it and then
Yes.
Try it again.
and again start? Yeah, please.
Yes.
Okay, I'm going to
I
close
think we
it.
can carry on because we can, yeah, now it's full screen.
Sorry.
Now it is full screen, I think. Okay, its slides are not showing presently.
You're right. I closed them up and I'm opening them
He
again.
closed and he will again share the screen. No?
Mhm.
Yes, I'm going to try that. Yep.
Yeah, please.
Okay, I've just shared the screen. Is it visible?
Yeah, visible the first slide.
It's visible now?
Yeah,
It's
visible.
visible, but it's not full screen. But
Now
I
I'm gonna-
think if it's
now,
we can
let me
carry
try.
on like this if it's because
Right.
we are able to read at least. If it's taking a lot of time, we can carry on like this.
I agree. I'm trying to get it to be full screen again, and let's see if we work. How was that?
Yeah,
Can you see that?
I think now it is.
I've
Yeah.
just changed the slide, or is that visible?
Yes.
It's not full screen. Someone just suggested that you'll have to share again via Zoom from the dialog box and select the entire screen or the slideshow tab.
Yes, I have done that. I don't know what's going wrong here.
So maybe we can
We can go through it only. Oh,
continue with what was
yeah,
there
please
earlier,
continue. Please continue.
with what was showing earlier, because this seems to be smaller than the earlier one.
Oops. Okay, I'm trying to change it back. Is that any better?
You'll need to hide the presenter's view now. When you did the right click, then there was an option there, hide presenter's view. So you'll have to go and click that.
Yeah, it's okay.
Yeah,
now.
it's better.
So So this is fine, sir, now, but you'll have to click on
Please continue,
slides
sir.
individually. Yeah, as you keep going down, you'll have to keep clicking on the slides individually. Yeah.
Okay, okay, I will do that. Thank you. Okay. Okay, I've moved to the research design. Are you seeing that okay?
Yes.
Yes. Yes, sir.
Okay, good. Well, sorry for the confusion about it. And okay, so thinking from the point of view of research design, we'll talk about mixed methods and then semi-structured interviews as an effective methodology to study resilient aging, particularly when we're looking at psychological and physical well-being and the interplay between them. Now, as we all know, and of course, as the Honorable Vice Chancellor has mentioned, quantitative research methods are absolutely essential for the statistical evaluation of changes in physiological and psychological status. We often use a pre-post methodology to look at changes together, and then to evaluate psychological status. It's quite useful to use a standardized measure of a resilient worldview, which can provide pre-post intervention comparisons. But, and here's where the problem arises, standardized measures do not provide sufficiently detailed insight about the specific cognitive schema or the mental attitudes and emotions that may be contributing to an individual's psychological growth or an individual's psychological dysregulation or to stress buffering resilience. And here it's useful to introduce qualitative research methods, and particularly those that employ a semi-structured clinical interview, because they're more useful for understanding patients' psychological status and functioning at this level of person-specific granularity. So the conclusion we can reach is to combine them both, that mixed methods research is a strategic combination of quantitative and qualitative data analyses, which creates a more comprehensive understanding of the interplay between mind and body in health promotion programs and other public health initiatives. So let's speak a little bit more specifically about semi-structured clinical interviews and begin to kind of deepen our sort of exploration of this material, because semi-structured clinical interviews are a very important source of qualitative data for health promotion studies or to study resilient aging. And so let me speak first about the protocol for qualitative analysis in which we're using a semi-structured interview. So first, in terms of protocol, the interviews are recorded and transcribed. And of course, this is this takes time and effort to have these transcribed, but it produces narrative data analysis, data for our analysis. And then in the second step, the narrative data is coded to identify a broad range of relevant issues. So let me give a couple of examples of coding kinds of categories from the kind of studies that we do. So one code might be a patient is showing resistance to participation in psychological self-inquiry, self-awareness, resistance to engaging in self-awareness activities. And another might be a patient now recognizing the need to strengthen psychological resilience, a second coding category. And a third coding category might be, evidence of psychological growth in their narrative data that comes from the semi-structured interview. So now we're beginning to create a broad range of relevant issues to include in our analysis. And then the third step would be to do what we call higher order coding, in which we look at the relevant issues that we've already coded and then categorize them into key themes. So one example of higher order coding would be to identify the different dimensions of psychological growth. In the first case, we're noticing evidence of psychological growth. Now we're going to code them into different dimensions of psychological growth. So some examples of these coding categories might be psychophysiological self-regulation skills. And a second might be cognitive schema, changing cognitive schema about self and others. And a third might be, oh, this patient is demonstrating social emotional relationship building skills. And these three coding categories come from work that I report in 2015, 2017 in my book. And you'll see that they'll go on playing a role in our analysis. And then one of the useful things about qualitative research, particularly of this kind of coding procedure, is that in fact, it can be quantified to a meaningful extent. So for example, somebody could be observing finally after this higher order coding, this patient's narratives showed 3 instances of growth in psychophysiological self-regulation skills. And it might be that they'd show many more or many less evidences of growth in other areas. And so we can begin to kind of look quantitatively at the qualitative research, at the qualitative data. And then, of course, finally, we come back to an integration of the statistical and the qualitative results, because it's the statistical analysis which will confirm or disconfirm growth in a resilient worldview, whether it's between 2 groups, a control group and an experimental group, or within an individual patient. But it's the qualitative analysis that will illustrate and explicate the either successful or unsuccessful growth. That's what's going to help us to understand with greater particularity what is happening in this patient and what is happening in other patients. So we both want to understand what's happening to our patients, as well as just be able to look at the larger statistical changes that give us evidence that an intervention is being successful or not. So here's an overhead that I won't spend any time on, but here's some useful reference material about semi-structured interviews, conducting them in use in primary care research. And I'll call attention to the final one, Ruth Ellen Josselson's Interviewing for Qualitative Inquiry, a Relational Approach. Good references if you need sort of more material on that, but I'm not going to review those carefully. Rather, let me turn to goal number 3 and begin to introduce the inventory of positive psychological attitudes, and speak specifically, as you'll see, that there are many different applications, 3 different kinds of applications of the IPPA. First, as we've been speaking about already, it can be used as a standardized quantitative assessment measure, useful in statistical research. But it also can be used as a self-assessment scale for mental health counseling. We can work with our patients looking at their answers, their responses to the scale, to kind of begin to understand what their growth process is. And as you'll see, the 32 questions can serve as a template for a semi-structured clinical interview. So it's a very versatile instrument in that we can be both using it for statistical standardized quantitative assessment, but at the same time, use it as a template for clinical interviews. So the IPPA measures a resilient worldview, confidence in life and self. It has 32 items, all on Likert scales that range from 1 to 7. We'll see that in a moment. And patients describe their current responses to stressful life circumstances. So it's not just asking in general, are you confident in life and self, but more think back to the stressful life circumstances that you're currently facing or have faced in your life and respond from that point of view. And there are two subscales: life purpose and satisfaction during stress, or LPS, and self-confidence during stress. I'll explain each of those a bit more. And combined together, they measure confidence in life and self. So here's the introductory page to the IPPA, which we give to patients as an introduction to resilience building and why they might be being asked to fill out their responses to the IPPA. So it's entitled A Resilient Worldview. And it reads, difficulties, serious problems, and crises are an inescapable part of life. The purpose of this self-scoring questionnaire is to help you strengthen important inner resources. These resources can empower you to face a crisis or a serious problem more effectively, either now or in the future, from a prevention point of view. And whether the difficulty is emotional, academic, medical, or a complicated situation in your life, whether it confronts you directly or someone you love, whether it's taking place in your family life or your work life or your personal life. In fact, your own inner resources strongly affect your ability to face and cope with a serious problem. And the most significant inner resource that you have is your worldview, your attitudes about life and self. Because if your worldview is resilient, you can respond to a crisis constructively. And a resilient worldview is characterized by feelings of confidence in life and self. In times of crisis or stress, you can retain a sense of meaning and purpose in your life. That's a big idea. In times of crisis and stress, you can retain a sense of meaning and purpose in your life. And in addition, you can remain confident that you'll be able to meet this challenge both through your own personal resources and through help that you receive from your support systems. So notice this is one of the ways that we're not simply talking about confidence as just simply as typically from the Western point of view, self-efficacy. I'm confident that I can handle everything by myself, but no, confident that I can meet this challenge both through my own resources, but also through help that I receive from my support systems, and whether that can include my own spirituality, as well as my family systems or my community systems. It gives us a lot of latitude. It gives each person latitude to develop different kinds of support systems in their lives. So we'll start from the standardized measure point of view that the IPPA has very robust psychometric properties. I'm not going to give you overheads on all of the different psychometric properties. That would take too much time for today's presentation, but referencing the papers, the book chapters that refer to those properties. And I'll just simply quickly say that the validation studies were quite rigorous. They included factor analyses of the individual items, of principal components with Varimax rotation analysis. We looked at scale reliability using Cronbach's alpha coefficients of reliability. We measured construct validity by correlating the IPPA with other measures, the profile of mood states, the Bradburn affect balance scale, the Rosenberg self-esteem scale, the UCLA loneliness scale, DeRogatis's symptom checklist 90. I'm sure many of you are familiar with at least some of those, and a different form of construct validity, the ability of the IPPA to discriminate between populations, for example, healthy graduate students versus outpatient treatment groups. And so it showed strong construct validity in both of those dimensions. And then I'll mention that the pilot study also produced meaningful research results. This was in a behavioral medicine treatment program for chronic pain. And we found that increases on the IPPA were strongly correlated with reductions in chronic pain. And here's where these results get interesting, because we were also measuring psychiatric symptoms like depression and anxiety. And of course, there were similar correlations, as psychiatric symptoms went down, chronic pain also went down, but the correlations were weaker here. The correlations were stronger with the IPPA. So from a positive psychology point of view, what we learned is that confidence in life and self, the IPPA, identifies health-promoting positive attitudes that are not fully tapped by decreases in psychiatric symptoms. Much of the earlier behavioral medicine research simply would use a measure of psychiatric symptoms to show, okay, if we reduce those, then we're going to get some positive results. That's correct. However, when we began to use, from the point of view of positive psychology, positive measures like confidence in life and self, we began to actually find more robust findings, really suggesting the importance of always looking at these positive measures, using positive measures as part of our research instruments. And I'll give examples. The IPPA has been used in good amount of research recently, over the past decades rather. So I'm not going to review the results on any of these, but just simply to show you a 2019 study of veterans participating in a therapeutic adventure program that was published in Psychological Services, a 2013 study of resilient worldview in male and female postgraduate students in the Indian Journal of Positive Psychology, another in the Indian Journal of Positive Psychology in 2014, resilience among sexually abused victims. From a more business point of view, worldview resilience of business degree graduate students in the Association of Employment Practices and Principles, the next of 2011 study, effectiveness of a yoga program for the improvement of well-being and resilience to stress in the workplace, was published in 2011 in the Scandinavian Journal of Work, Environment and Health. My own work in 2015, reporting on using the IPPA in a quasi-experimental mixed method study in the Journal of Humanistic Psychology. A couple more, 2014, again in the Indian Journal of Positive Psychology, a study of resilience amongst the Tibetan refugees living in India. A study in 2012 on the mental health benefits of yoga in a secondary school in the Journal of Behavioral Health Services and Research. Another yoga study in 2013, yoga as a predictor of psychological wellness in women in the International Journal of Yoga. Another here, benefits of yoga for psychosocial well-being in the US high school curriculum in the Journal of Developmental and Behavioral Pediatrics. And finally, incorporating spirituality into health sciences education that was published in the Journal of Religion and Health. So as a standardized instrument measure useful in health promotion research, the IPPA has really been found some real use. So let me turn to the IPPA itself and introduce you to it quickly. And so we'll start by looking at the life purpose and satisfaction scale. And I'll go through this very quickly, but just point out a couple of things. So here's the Likert scale. So for example, item number 1, during most of the day, my energy level is, and the patient can rate it from very low to very high. Or number 2, as a whole, my life seems dull, low, or vibrant. And note immediately the potential for what I call narrative unpacking. There's a story here. We can say to a patient, well, you've scored number 2 here on, or number 5 here. Tell me more about that. Or number 3, my daily activities are not a source of satisfaction, a source of satisfaction. Each of these items has a story behind it. And so I'm introducing to you where a semi-structured, in-depth clinical interview can emerge from this material. I've come to expect that every day will be exactly the same, new and different. When I think deeply about life, I do not feel there's any purpose to it. I feel there is a purpose to it. I feel that my life so far has not been productive or been productive. There's a story in each of these. I feel that the work I am doing, it doesn't have to be income producing jobs. It can include childcare, housework, studies, volunteer services. But I feel the work I'm doing is of no value, is of great value. Another important question that needs to be unpacked often. I wish I were different than who I am. I can agree with that or strongly disagree with that. At this time, I have no clearly defined goals for my life. I have clearly defined goals for my life. Or when sad things happen to me or other people, I cannot feel positive about life. I continue to feel positive about life. Or when I think about what I've done with my life, I feel worthless or worthwhile. And the last set, my present life does not satisfies me, or I feel joy in my heart, never all the time. Listen to this one. I feel trapped by the circumstances of my life. I agree. I feel trapped. I disagree. When I think about my past, I feel many regrets. I feel no regrets. Or deep inside myself, I do not feel loved. I feel loved. When I think about the problems that I have, I do not feel hopeful about solving them, or I feel hopeful about solving them. And then I'm shifting to now the self-confidence during stress, kind of a different dimension. So picture this or listen to this. When there's a great deal of pressure being placed on me, I get tense. I remain calm. I react to problems and difficulties with a great deal of frustration, with no frustration. In a difficult situation, I'm confident that I'll receive the help that I need. No, I disagree with that. I don't think I'll receive the help that I need. Or yes, I will. During stressful circumstances, I experience anxiety. All the time? Never. When I've made a mistake during a stressful situation, I feel extreme dislike for myself. I continue to like myself. When a situation becomes difficult, I find myself worrying that something bad is going to happen to me or those I love, catastrophizing. All the time? Never. In a stressful situation, I can concentrate easily. I said it backwards. I cannot concentrate easily. I can concentrate easily. During stressful circumstances, I'm fearful all the time? Never. When I need to stand up for myself, I cannot do it. I can do it quite easily. I feel less than adequate when I am in difficult situations. I agree strongly. I disagree strongly. I do feel adequate. And the final ones, during times of stress, I feel isolated and alone. Yes, I do. No, I don't. In really difficult situations, I feel unable to respond in positive ways. I feel able to respond in positive ways. And another important one, when I need to relax during stressful times, I experience no peace, only thoughts and worries. I'm always worrying. Or when I need to relax, I can experience peacefulness, free of thoughts and worries. That's, of course, part of what we teach people during meditation practice. When I am in a frightening situation, I panic. I remain calm. And during stressful times in my life, I worry about the future all the time, another form of catastrophizing, or never. So those are the 32 items. And looks like that we got a bit of a drawing got added on to this, and I'm not sure where it came from, but I'm not going to worry about erasing it now. I apologize. Not sure how it got there, but let me just mention then quickly that in terms of scoring the IPPA, you can calculate 3 scores. Number 1, life purpose and satisfaction. 2, self-confidence during stress. 3, confidence in life and self. And simply we take the sum of each of those scores, we divide them by the number of items in the particular scale, and each score should range between 1 and 7. And scores can include decimal points, like 5.15. And if we're thinking about the interpretation of the scores, it's divided into 4 quadrants: high, medium, low, and low. And I'll say that in the work that we've done in the USA, that most adults score between 4.03 and 5.87, more or less in the medium-high range. The average score, 4.95. And then these questions just ask you, the patient, to kind of reflect on their answers and to see if they make sense to them. And I'll say more about that when we really give the kind of the clinical example here. But let me try to offer some practical details, or guidelines rather, for semi-structured clinical interview now, where we're using the IPPA as a template. So talking again from the point of view of protocol, we'll begin with a clinical intake that takes 30 minutes, where the clinician meets the patient, reviews reasons for the referral, reviews reasons for participation in resilience building counseling. And the clinician can present the introductory page of the IPPA, which we looked at earlier, a resilient worldview. And then the clinician requests the patient to complete the IPPA after the intake session so that the clinician can review it. So the second step is for the clinician to prepare for the semi-structured interview, also taking about 30 minutes on her or his own, where the clinician scores the IPPA scales and reviews the patient responses to the individual items to think about what might need to be unpacked, what might need to be understood. And then number 3, the clinician conducts the semi-structured clinical interview, the first of 2 semi-structured clinical interviews, and taking an extended period of time, up to 2 hours. And the purpose of this one, and notice, is to understand the problem and the issues from the patient's point of view, not to immediately arrive at a solution, a diagnosis, advice, but to make sure that we've unpacked the issues and understand them from the patient's point of view. The clinical example that I'll give will help to explain that. And then after that first interview, the clinician will review both the counseling methods and the narrative data that came from interview number 1, spending about 30 minutes on that. And the clinician can then begin to conceptualize the patient responses through a 5-dimension model for building psychological resilience that we'll look at in a moment, that comes from my own work. And then finally, the clinician can return to meet with the patient for a second semi-structured clinical interview, can also take up to 2 hours. And here the purpose is a little bit different: to set goals for building psychological resilience, to engage in a collaborative process. Now, in this presentation, we won't have enough time to look at interview number 2, but interview number 1 will give us sufficient insight to kind of see where we would go also with number 2. And I'll mention a couple of more practical guidelines as we begin. And these refer to certainly my work with Dr. Carl Rogers, a founder of humanistic psychology, who was an important mentor of mine, thinking about what are the interpersonal conditions for effective counseling and effective interviewing. And the first is to say it's person-to-person communication, not authority to person, but to really understand that we're looking at our patients as human beings, just like ourselves, with problems that they don't know how to solve. So we can show them the respect that every human being deserves, and we can communicate compassion and caring, what Dr. Rogers called unconditional positive regard for the patient as a distressed human being. And then we can begin to try to understand the patient's problem from their point of view. And this means that we need to demonstrate accurate understanding of their viewpoint. And so Dr. Rogers worked on developing what he called empathic reflective listening. It's not simply that I think I understand what the patient is saying, but that I reflect back to the patient what they're telling me so that they know that I'm understanding them. That's a key aspect of this, and you'll hear more examples of that. So particularly there, I don't know if I'm touching something, and I hope not, but the little lines are just appearing here. But I'll stick with empathic reflective listening is don't give advice. Don't disagree with their cognitive distortions immediately, even though you as a clinician may be sensing some cognitive distortions, because your first job is to try to understand their viewpoint. It's only later, when the therapeutic alliance for setting goals has been established, perhaps in interview number 2, that we can move into a more directive approach. So we're learning to wait patiently until the conditions are ripe to offer honest feedback, or what Dr. Rogers called congruence. So a very important sort of set of practical guidelines to really practice reflective listening. So next, we'll kind of just say that from the point of view of the protocol, that we want to begin to develop a conceptual understanding of the patient's issues. So the clinician will review the IPPA scores, will review the particular responses to the IPPA, and review the conversations that we've had, and kind of ask myself as a clinician the question, what is this material telling me about the patient, or not yet telling me? And from the point of view of preparing for interview number 1, my goal is to understand the problem from the patient's viewpoint. So what responses require narrative unpacking to understand their meaning more fully? And in interview number 1, I'm going to focus on letting patients unpack their story, their perceptions, their emotions, so that I, the clinician, understand them, but also so that they feel understood by me, the clinician. That's the crucial idea here. And then finally, as I'm listening and reviewing their material, as I review interview number 1 in preparation for clinical interview number 2, that's where I'm working to develop a conceptual understanding of the 5 dimensions of self that can become dysregulated when patients lack psychological resilience. So here are some of the higher order coding categories that we'll ultimately use in our research, but that I'm using now as a clinician to be thinking about what I'm learning about this particular patient. And these 5 areas, whether the patient is demonstrating psychophysiological self-regulation skills, both emotional and behavioral self-regulation skills, what kind of cognitive schema and social identity or cultural identity narratives does the person have about him or herself and other people? What is their relational attachment style? What are their social emotional attachment skills? What's their perceived relationship with life itself, their underlying existential worldview? And finally, do they integrate these in any way to show confidence in life and self during stress and crisis? So these coding categories are useful in research, but they're also useful in clinical work to be thinking about what we're learning about a patient and their abilities to cope with stress, and where there are areas of strength and where there are areas of weakness. So here it'll be useful to just jump into the illustrative case study, a patient who I'll call Martin, who was an Italian-American male, age 64, and it was verbal style. I'm telling you a little bit about just the intake interview now, as I just first met him. It was verbal style, was very gregarious. So as he said, call me Marty, not Martin, not my formal name, or call me Marty, like my friends do. Learned a little bit about his employment, that Marty and Bella, his wife, own a very successful Italian restaurant for over 30 years. And Marty explained, I'm the man. I'm the chief chef. Bella supports me, managing the dining room. So I began to learn something about how his own cultural identity narratives. And reason for referral to behavioral health counseling. Well, Bella and my cardiologist insisted. They're overreacting. You know how wives can be. And explaining his history. I had a mild heart attack when I was 57. You know, atherosclerosis, stents, statins, you know, the whole deal. They sent me to a stress reduction program. It was useless. I'm fine now, fully recovered. My wife, my friends, my doctor, they shouldn't be so worried about me. This is him in the clinical intake interview. So I'm getting a lot of information, of course, about this patient, his resistance to treatment, his resistance to his cardiologist, his resistance to his wife. Talked a little bit about symptoms that led to the referral. Well, you know, my wife and friends noticed, yeah, I'm having some shortness of breath climbing stairs, but it's not such a big deal. And we talked a little about lab results that he had. Well, weight gain, high blood pressure, high LDL, triglyceride, but I'm 64. What do people expect? And so the cardiologist sent Marty once again to a stress reduction program. I quit after the first session. It was stupid. I'm not stressed. I'm a strong, easygoing guy. So the cardiologist then suggested a counselor who helps people build resilience. Well, okay, that sounded okay, at least for a try. I'm sure that you'll see I'm a strong, resilient, relaxed kind of guy. So I'm kind of overplaying his tone a little bit, but just to kind of give you a flavor of what it was like to meet this very resistant, very self-assured, in quotes, self-assured kind of person. But Marty was introduced to the IPPA and he agreed to fill it out. And his scores, well, it'll turn out that his scores surprised him because on life purpose and satisfaction, he scored 2.88, which you can see is actually medium low. And his self-confidence during stress was 4.60, higher, but only medium high. And altogether, his confidence in life and self was 3.69. So really in the medium low range and below the average score of 4.95. So of course, the clinician recognizes this after the intake interview and thinks, now Marty thinks he's in better psychological shape, more resilient than he actually is. So clinical observations after the intake session and then the IPPA scores. From the intake session, Marty is resistant to treatment and lacks self-awareness. He insists that he's not stressed, but he expresses marked frustration toward his wife and doctor. He identifies himself repeatedly as a strong male, and his male socialization patterns appear to prevent emotional vulnerability or non-defensive communication. And then when we look at his scores, Marty's IPPA scores reflect a diminished degree of confidence in life and self. The scores are quite below the national average and range, not enough to raise an urgent clinical alarm, but definitely too low. Marty believes that he's resilient and relaxed, but his IPPA scores suggest otherwise. He's actually more distressed and emotionally dysregulated than he was able to admit during the intake session. So these are my reflections. It's not that I'm saying these things to Marty immediately. I can see that his sense of life purpose and satisfaction is particularly low, but paradoxically, his self-confidence during stress was appreciably higher. So that led me as counselor to examine his individual responses to try and understand this marked difference before the clinical interview. And let's just look at those very quickly, and I'll just point out a couple of interesting things. But you can see right from the beginning, during most of the day, energy level, he marks quite low. As a whole, my life seems dull, more dull than vibrant. Now notice number 3, my daily activities are not a source of satisfaction or a source. Well, Marty wrote 2 things. He circled number 2 and scratched in the word now. And then he wrote for number 6. That was before. And I'm thinking, interesting. Marty's already starting to tell me something about a story that's going on in his life. that I might need to understand. And you can see that the next couple of these remain low or sort of middling low. Similarly, the work that I'm doing, medium high. I wish that I were different than who I am. No, I like who I am. I disagree strongly, but define goals in life rather, in the middle. When sad things happen to me or other people, I can't feel positive about life. When I think about what I've done with my life, I'm feeling worthless. He's telling me the beginnings of his story. My life doesn't satisfy me. Joy in my heart, number 3, pretty low. I feel trapped by the circumstances of my life. Number 1, I agree strongly. I feel trapped. When I think about my past, many regrets. And here's another one where he wrote in 2 different responses. Deep inside myself, I do not feel loved. Now, I do not feel loved. Before, number 6, I did feel loved. What happened, Marty? This is a story that needs to be unpacked. When I think about the problems that I have, I don't feel hopeless about solving them. When I look at self-confidence scores, now I see where he always considers himself very calm and resilient. When there's pressure placed on me, I remain calm. When I react to difficulties, no frustration. In a difficult situation, I'm confident that I'll receive the help that I need. No, I don't feel confident of that. During stressful activities, I'm never anxious. When I've made a mistake, dislike for myself, do I like myself? Kind of caught in the middle. When a situation becomes difficult, I worry all the time about there's something bad is going to happen to me or those I love. So he does catastrophize, despite saying that he's so calm and resilient. In a stressful situation, I can concentrate easily. During stressful, I'm never fearful. When I need up to stand up for myself, yes, I can do it. You can see the picture of what he's kind of saying here. I feel able to respond and strong in positive ways, but number 30, when I need to relax, no peace, only thoughts and worries. Number 32, I respond during stressful times. I worry about the future all the time. So a very contradictory set of responses. So 2 items really what stood out were the ones that he wrote now and before. Daily life is a source of satisfaction. Deep inside myself, I feel loved. So these comments suggest a change in his life that's causing him distress. And this is the underlying story that needs to be told and unpacked during the interview. And I'll give just some examples of that. And also why the SDS scores are higher. Well, he claimed to be relaxed and confident during stress in a whole number of those items, which of course he made similar claims during the intake interview, despite presenting himself as frustrated and stressed. But you see the same contradictions in 3 SDS items. He worries that bad things will happen. He feels isolated and alone. When he needs to relax, his mind continues to focus on his worries. He often worries about the future. There's real contradictions that are going on here. Now, the clinician, me, realizes it may be most strategic to wait for interview number 2, where we're building resilience goals, to explore all these contradictions, because for interview number 1, I want to focus on letting Marty tell and unpack his story. And I'll just do that briefly before I end my comments for today. So let me just give you some examples from the semi-structured clinical interview. The first one, selected points of conversation. And I think here you'll be able to hear the flavor of Marty, but you'll also hear the particular way that the counselor responds that focuses on trying to understand his point of view. So we looked at the IPPA scores, and Marty was, quote, surprised to learn that his IPPA scores were lower than he expected. And the counselor responded, well, looks like we have a mystery here to figure out. In other words, I didn't say, oh, don't worry about it. They're not that low. I wasn't trying to alleviate his worry about it. It was more like, well, let's use this as an introduction. We've got a mystery here to figure out. So Marty, as we kind of go on a little further, begins to show some visual signs of distress. For example, I can see some tense facial muscles, and he responds, yes, I'd like to figure this out, but I don't know how we're going to figure this out. It's different than what I expected. I expected just to be seen as just positive and resilient. It's different. And again, a careful response by the counselor. So it sounds like when things turn out different than you have expected, you feel disappointed and confused. So I'm reflecting back that confusion. Now, of course, I'll be empathic and say, and compassionate, these feelings are understandable. I mean, that happens for many people. And then I'll be a little directive and say, but let me suggest a place for us to begin, because I think it would be helpful to discuss items 3 and 16. Those were the now and before ones. So Marty says, okay. So I point out as the counselor, now there's a pretty big change between now and before. So I hope you might be willing to explain it to me. What's the story behind these big changes? So we jumped into the interview more deeply, and Marty told me a lengthy story about the past 10 years. Because from his point of view, he was betrayed by his wife and adult children, his 2 sons and a daughter. So just here are some selections that'll give you a taste for this. But let me point out that throughout the interview, as the counselor, I realized his sense of betrayal might actually be a cognitive distortion. It's not necessarily that he is right, that this is the truth from everyone's point of view. But my job is not to disagree with his perceptions right now, or not to try to assure him, of course your family loves you. No, they wouldn't betray you, because that would have interrupted his narrative about his story. So I'm working to listen and help him unpack his own story. And I'm going to respond with reflective listening in order to understand his perceptions and feelings so that those become more visible to him, more experienced and clear to him. So examples, Marty said, I couldn't believe my sons wanted to change the menu of our successful restaurant. Here's a key to something that was going on. I couldn't believe my sons wanted to change the menu of ours. He wanted his sons to join him, to take over the business. And they made some suggestions to change the menu. I can't believe my sons wanted to change the menu of our successful restaurant just because many of their friends have become vegans. So you can see the story. The sons want to join, they want to help dad, but they also want to be modern and up to date. Their friends are, many of them are become vegans, and they're just suggest. So I can see the distortions that are there, but I'm not disagreeing with him. I'm not telling him all these perceptions. Instead, the counselor responds, oh, so you were genuinely shocked that they disagreed with your decades-long successful menu. That's what he's trying to tell me from his point of view. So as he went on with the story, we kept on battling. Then they threatened to leave the restaurant and start their own. Well, what the heck? I wasn't going to back down. Let them fail on their own. So the rupture was growing. But again, I'm not pushing that back on him. Hey, Marty, you made a mistake. I'm reflecting, oh, you were so angry, you just dug in your heels and stuck to your convictions. And then it goes on later. So they really did quit the business and start their own restaurant in a nearby town. But the crowning blow came when our daughter graduated from college that spring. Counselor, what happened? Marty, she told us she wanted to become a lawyer and didn't want to follow in Bella's footsteps, supporting him. So the counselor says, oh, so both of you must have been devastated. And Marty says, no, not Bella. She was proud of Sophia, delighted. I was devastated, which angered Bella. Counselor, oh, I see. Bella wanted Sophia to have a professional career, but for you, it meant that your children would not carry on the business that you had worked so hard to build. And a little later, Marty says, and all of that was the beginning of Bella betraying me. What do you mean? Well, for starters, she kept inviting them for Sunday night dinners, even though I told her that I didn't want to see any of them ever again. So she insisted on maintaining a relationship with them. And I'm guessing that felt like a major challenge to your authority as her husband. Marty nods his head, yes. And when I insisted, okay, that it was time to sell the restaurant, in other words, he was so angry and depressed. He said, Bella, it's time to sell the restaurant. When I insisted that it was time to sell the restaurant, she told me she would move out of our house to be closer to the boys. And the counselor says, so everything fell apart. And now Marty begins to have some tears in his eyes. Yes, everything has fallen apart. And a moment later, Marty's head bowed, tearful, quiet. And I say to Marty, you know, Marty, the more we speak, the more I understand how sad you feel. Your whole life purpose has been drained away from you. And he just nods his head, yes. And I say, as counselor, I feel for you, Marty. This has been very hard. I can understand how angry you feel. I also know how sad you feel. So I'm reflecting and naming an emotion that he hasn't always acknowledged to himself. So here's the final part of this first interview, because even though it's not interview number 2 yet, I've already got a picture of what's going on, and I've begun to form a therapeutic alliance with him that he can feel that I empathize and understand. So I say towards the end, Marty, before we end today's session, there's something I want to ask. I know that your family has experienced your anger, but do they know about your sadness? And Marty responds, frustrated, they should be able to figure that out. And I say, I'm not so sure, Marty. You know, anger pushes people away. Sadness draws people close. And he says, I couldn't show them my sadness. And I say, well, do you mean strong men don't do sadness? And he says, something like that. And the counselor says, well, sometimes showing sadness is needed. That can be more important than acting strong. And then Marty begins to get the feedback that I'm giving him. You think that I have been pushing them away? And I respond as counselor, could be, Marty. That's something that we should think about together in our next meeting. So I'll pause there and just make some comments as a way to kind of finish up the presentation for today. But you can see that what's happened is that by listening to Marty reflectively, he was able to tell his story. And as he told his story, he reached deeper levels of his own emotional reality. And as he reached those deeper levels, he was able to hear things from inside of himself and also hear things from me that he wouldn't have been able to hear before. So in conclusion, I could say that examining Marty's IPPA scores with him provided a structure which led to an important conversation. And this conversation, the semi-structured interview, explained his diminished sense of life purpose and satisfaction very clearly and very poignantly. And I could say that reflective listening and empathic questions helped Marty tell his story from his perspective. And of course, throughout the interview, the counselor recognized potential distortions in Marty's perspective, but the primary goal of the interview was to understand his perspective and for Marty to feel understood. Because feeling understood helped Marty shift into his underlying emotions, a shift from anger and bitterness to sadness. Marty had not previously had emotional access to this sadness. And so clinically, this was an important step in this interview. Because once Marty experienced his sadness viscerally, and once he could feel that the counselor was touched, understood this, then Marty could entertain the counselor's comment about sharing his sadness without becoming defensive. And so I could say from a next level of kind of clinical understanding that if I apply a conceptual model of the 5 dimensions of self that become dysregulated, I could speak about Marty this way. Lowering his defensive armor is going to be an important step for Marty in repairing his ruptured family relationships, but also becoming more compliant with the treatments that his cardiologist has suggested, including becoming more receptive to the counseling that's being offered to him. Because up until now, his cognitive schema about men, we need to be strong, has impaired his relational attachment style. He chases people away. And as Marty learns to acknowledge the negative consequences of his rigid cognitive schema, then he can develop psychophysiological self-regulation skills. Take a deep breath. Listen to the Marty. Don't yell reactively. Share your sadness because it reveals your deep love for your family. So you can see where progress can be made and did ultimately get made. As he heals the ruptures in these important relationships, then the restaurant can continue to be a source of life purpose and satisfaction. And at the same time, he can develop the self-confidence to forge new forms of connection with Bella and their children. Because becoming a healthy husband-wife team as their children individuate as adults is an important step in resilient aging. So I'm at my final overhead, but glad to have shared the clinical example with you to kind of really sort of concretize everything. So let me say that I hope that this has been helpful. This presentation has offered some practical guidelines for conducting a semi-structured clinical interview. It's demonstrated how narratives from the interviews can provide granular phenomenological data to explicate the process of psychological growth, adding insights that augment statistical verifications. So for this reason, mixed methods research is a highly useful tool in health promotion studies. We've also introduced the inventory of positive psychological attitudes, both as a standardized measure for statistical investigations, but can also serve as a template for effective semi-structured clinical interviews. And the case study of Marty suggests the clinical value of utilizing the IPPA in studies of resilient aging, because the IPPA can serve multiple purposes in a mixed methods research design. So let me just pause for a moment. This is my kind of final moments of just saying that this presentation is part of my collaboration with Dr. Nisha Pandey to develop a project on resilient aging across the lifespan through my work as a Fulbright specialist in global public health. And I hope that this will be a first step. We hope to include the Department of Psychology from the University of Lucknow in this collaboration because of their valuable work in positive psychology. And I certainly look forward to additional presentations at KGMU and with all of you as we move forward on this collaborative project, because projects require collaboration and support. And as Dr. Pandey knows, there are next steps for us to take together to move this project into its most concrete stages. So I hope that this has been a good introduction. both to mixed methods research, to semi-structured clinical interviews, as well as to a potential project on resilient aging across the lifespan. So thank you very much for your time.
Thank you very much, Professor Kas. It was really very invigorating session. As a lifelong research scholar, I have gained quite an insight into mixed method research today. And I think there is no question left for question answer session now, because it is extremely extended and integrated topic. From conception to execution, each step is important for carrying out the mixed method research in studies, and you elaborated each and every step very well. However, there are participants who might be trying to have an interactive session with you, and they might gain knowledge from it. They want to discuss with you. So I am opening the floor for interactive session. Over to participants. Please write in the chat box or unmute yourself. Farhan, I would like to request you कि प्लीज माइक अनम्यूट कर देंगे जो भी क्वेश्चन पूछेगा. फरहान. Participants, please ask question.
Hi everyone, my name is Deekshita and I am a research scholar at this Tata Institute of Social Sciences. I am primarily a qualitative researcher by choice. And Dr. Kas, I just wanted to ask you a thing or two on your presentation for mixed methods research.
Please.
As I see it, qualitative data does provide you a richer and deeper understanding of perspectives of the participants of the study, as opposed to quantitative data, which is more gravitated towards numbers and quantity. But at the same point of time, I wanted to know what makes you switch towards going for mixed methods research. At what point do you decide that getting opinions or perspectives of participants is not enough, and it also has to include a larger number of data points in your research? At what point do you actually, should you actually wish to switch towards mixed methods?
This is a very thoughtful question and a very helpful question. And let me respond to you, with great respect that you're a qualitative researcher. And of course, you understand the value and the depth that comes from qualitative data and analysis. And there are many studies where qualitative analysis and qualitative data are more than sufficient for particular studies. It's so important to understand the depth of what individuals are describing, their own experiences. So let me appreciate your question and correct myself to kind of say, it's not that I'm needing to imply that all research needs to use mixed methods. I have just the tremendous respect, and I wish that the medical world and the psychological world and the sociological world and the public health world did have greater appreciation for the importance of qualitative research. It's just essential, and for too long we relied simply on quantitative data, which just is not sufficient. So I think it's a choice point, and I think that at a certain point I began to understand that in some studies, and when I wanted to have some impact also on more traditionally trained quantitative researchers, that it would be useful strategically to integrate qualitative and quantitative together. And also not just to simply say it as a strategic piece, but as I kind of said earlier in the talk, there are times when we really do want to verify changes and compare an experimental group to a control group and find some quantitative measures. So it's not so much a particular number as it is, what's the strategy, what's the goal of the particular research that I'm doing? And in many cases, it's absolutely appropriate and correct to remain focused on the qualitative research and qualitative data. And I'm sure that you have already had the experience of just how useful that is. So thank you for raising the question and kind of bringing it to everybody's attention. I think that's a good corrective to a good commentary on what I've presented. Thank you.
Thank you for the answer.
Hello.
Pleasure.
Thank you, sir.
Hello. I am Dr. Salent Montepati. I am Associate Professor in Geriatric Mental Health. I am a psychiatrist by profession, and I was listening to you quite recently, and it was quite informative and quite useful topic, not for just for the interviewing technique in research methodology, but the way you have explained the communication skills and interviewing techniques, that would be quite useful in the clinical settings as well. And that's really great to be part of your presentation. I have a very quick question from you. You have been talking about spirituality and psychological resilience, as you have very great interest in our Bhagavad Gita and spirituality in India. So what is your take on spiritual resilience? There's a new thing which I come across when I was going through this topic. So, and how the mixed method techniques can be applied to evaluate spiritual resilience. Thank you.
Well, thank you also for this excellent question. And let me respond in two ways. That first of all, I hope that your question will lead Dr. Pandey to a follow-up webinar where we can talk about spiritual resilience in even greater detail, because you're asking a complex and important question. And I'll say first that I'm very glad that you found the comments useful from a clinical point of view, because just so often we think that our goal as clinicians is simply to give advice or to suggest what kind of solution a patient needs to their problems. And we get caught in what we call a fix-it mode. Our job is to fix it, as opposed to our job is to help unpack what's going on for the client. Because central to what I've learned from the spiritual teachings of the Indian tradition and many other spiritual traditions is that we have wisdom inside of us. Each person has wisdom inside of themselves. And that what they need to learn to do from a spiritual point of view is to tap the wisdom inside of themselves. And in this case, Marty made a small step towards that. A small step, because when he's able to say, do you mean that maybe I'm the one who's chasing them away? He's coming closer to the sad feelings that he's feeling inside of himself. And he's beginning to hear, the possibility of some within himself. Maybe I am part of the problem here. And that's the journey towards inner self-knowledge that ultimately might lead him to be able to restore the rupture in his relationship with his wife, with his children, go on with the restaurant, and then to restore a sense of life purpose. And of course, part of what spiritual resilience is about is feeling that life is purposeful even in the midst of struggle. So he's beginning to learn that his struggle itself might be a teacher to him and help him to grow spiritually. So I think I'm answering clearly, but perhaps I'm having to say too much too quickly. It would be certainly a very useful conversation for us to continue further. But thank you very much for the question, and thank you for your sensitivity to the kind of clinical responses that I described in the interview with Marty. Thank you.
Thank you.
Thank you, Jared, and thank you, Dr. Shailendra, for your question. Anyone else want to ask anything? Is there any question? I think this session was very clear, very informative, and there are so many things stepwise you elaborated that nobody, everyone has a clear mindset that how and when to start mixed method research and how to go for clinical interview, what steps should be involved in a clinical interview, and the take-home message is wait patiently unless conditions arrive for offering honest feedback. So if there is no question, can we go there? Before that, I would like to say that mixed method clinical interviewing skills require both relational focus and practice in the skill of facilitation, for which Professor Kass regularly said that there should be many steps and that should be followed properly. One must know that how to determine the purpose and scope of the study. For that, an in-depth identification of problem should be there. Then one should identify what is to be done, who will be the participant, what can be the ethical aspects, for which Dr. Akash very nicely given the example, and what will be the logistic aspects, what is to be planned, how it should go, and then develop a proper interview guide, which is a must. And I will, Kaas has permitted that we should share the PPTs with audience. So I make sure that we will share the PPTs. So for doing the clinical interview, qualitative interview, it is very necessary that first establish trust and rapport, and there should be an ability to memoing and reflection, reflective listening, so that we can conclude it properly and we can code it and decode it and then analyze it and present it in a scientific manner. That is what I take home message. Now this is the time to give take the feedback, because no research is completed without a feedback. So I am going to share a feedback form which is through Google link, and that feedback form to be filled within 15 minutes, and it will be shared through your email also. And I think when it will be shared, please do it within 15 minutes. Otherwise the link will be disabled, and everyone will, whoever will give the feedback will get the participation certificate also. So here is the feedback form. So this was really an amazing question answer. Most of the queries were satiated. Wonderful session by sir. So thank you, Professor Kas. To express our gratitude, I would like to invite Vice Chancellor, sir, for present memento, appreciation memento to Professor Jared.
Dr. Nisha, if you, I think you have to allow me to start video.
Sure,
think-
sir. Sure, sir. No worries. Sir is, yes, sir. Please, sir.
So I just want to, in the end, I just want to express once again my deepest gratitude for an amazing deliberation on a topic which is so contemporary, so so important for us as clinicians as well as researchers. And in that context, I think it's been just a wonderful afternoon for us here. Once again, thank you, Professor Kas, for this excellent deliberation. And we can't thank you enough. And I'm sure we look up to you for further guidance and future deliberations in times to come. And once again, on behalf of the King George Medical University, I would request you to accept, at least virtually, this certificate of appreciation from this medical university. Professor Kas, please.
Thank you very much, Dr. Puri. I'm proud to accept the certificate and honored and just delighted to have the opportunity to share these ideas with you and look forward to ongoing discussion about these ideas. I think that there's a great hope to kind of develop projects like this.
Thank you so very much. Thank you so much. Thank you, Nisha. Thank you for an excellent conduct of this webinar. And thank you all for joining in on this online platform for this very interesting, very fascinating, very intriguing webinar. Thank you, ladies and gentlemen.
Thank you very much, sir. Thank you for your support and encouragement. Thank you so very much, sir. Thank you, everyone, for being such an interactive and involved audience. We hope you are taking away as much as you have given us today. Dr. Kas, thank you for your being here and sharing your experiences and knowledge with all of us. And now we are at the end of this grand session, and I would like to invite Dr. Pooja Mahor to express vote of thanks. Thank you. Over to Pooja.
Everyone, respected guest speaker, friends, ladies and gentlemen. It's my proud privilege to propose vote of thanks on behalf of Research and Development Cell of KGMU, Lucknow. Our heartfelt thanks to Professor Jared D. Kass for taking time out for us and agreeing to speak upon semi-structured interviews in mixed method research. Sir, we are enlightened with your knowledge, experience, and interesting style of explanation. We are obliged to our patron and the Honorable Vice Chancellor, Lieutenant General Bipin Puri, sir, for your guidance.
Sir, no voice is there.
There is a glitch of internet. I would also like to thank Professor Uma Singh ma'am, Dean Faculty of Medicine, and Professor Shankar sir, CMS, for being with us, who guided us, clarified our doubts throughout the process.
We also wish to thank Professor Shelly Avasthi ma'am, chairperson of the webinar and Dean Research and Development Cell. Ma'am, we are really thankful for your meticulous and motherly support throughout the presentation process. I would like to thank members from Advisory Committee, Dr. Shrikant Srivastava, Professor Monica Agrawal ma'am, Professor S.K. Singh sir, and Professor Somendra Singh for their timely guidance and support. We would like to extend our sincere thanks to all the participants incorporated from various places for this webinar. Your involvement, queries, and active participation has made this webinar more interesting. I would like to thank Dr. Richa Khanna, in charge IT cell, and all the technical staff involved behind the smooth conduction of this webinar. We would like to thank Dr. Sudhir Singh, in charge media cell, and his team, personnel from press and media. I would also like to thank our organizing team members, very motivated and dedicated colleagues whose untiring efforts, unity, and hard work has made this event successful. I extend my gratitude to all the people who supported the webinar directly or indirectly. Ladies and gentlemen, once again, we all are grateful to you for being with us. Thank you so much.
With this, we come to close on our webinar for today. So thank you all. Take care and goodbye. Thank you. Thank you, everyone. Can we take a photograph? Please open your video. Somendra sir, can we take a photograph? A screenshot of this moment. Okay. Thank you. Thank you, everyone. Thank you, Jared. Thank you very much.
Thank you very much.
Thank you, Nisha. A pleasure. I'll talk to you soon. Namaste.
Okay.
Namaste.
We will definitely do something. Namaskar.